I am Jess Rude. I'm Executive Director of Alaska Eating Disorders Alliance. Today's ECHO offers a forum for interdisciplinary healthcare professionals to connect with eating disordered experts and each other. The program today is going to include a didactic presentation, time for questions and answers, and a case presentation. The series has been guided by a hub team of professionals in the field. They will introduce themselves in the chat too. Just want to do a little housekeeping that we couldn't do this ECHO series without the generous financial support of ConocoPhillips Alaska. Thanks to their support, we can offer this world-class educational event at no charge to participants like you. You can claim 1 credit hour for continuing education if you attend at least 90% of today's live session. After the session, a link will be provided and you can complete an evaluation and download your certificate. Just a few Zoom reminders before we get going. The CC button at the bottom, we already talked about. If you're able to today, please keep your camera on and your microphone muted unless you're asking a question. The hand feature is a great thing to use. We do encourage questions. Please, you can actively use the chat box. We'll answer as many as we can as possible with time allowing. And one more thing is that the opinions of the hub team and the presenters here today are their own and do not necessarily represent those of AKEDA or any ECHO sponsors. Additionally, Project ECHO is not HIPAA compliant, so no protected health information is to be shared or displayed at any time today. I know that's going to be easy for everyone to follow those guidelines. Lastly, we acknowledge that we're hosting this session from Anchorage on the unceded lands of the Dena'ina people who have lived in these unceded lands for thousands of years. We thank the Dena'ina people for their stewardship of the lands, water, air, and all life that sustains us, and respect the Dena'ina cultural ways and homelands. We all strive to be good neighbors. And so on to our presentation today. Our didactic presenters today are Dr. Cara Bohon and J.D. Ouellette. Dr. Cara is a clinical psychologist with over 15 years of experience as an executive, clinician, and researcher in the eating disorders field. Her research focuses on identifying underlying factors like brain function and body image to develop effective interventions. Her work has been published in top-tier journals, and she was awarded an Early Career Investigator Award from the AED. Dr. Bohon earned her Ph.D. in clinical psychology from the University of Oregon and is a clinical associate professor at Stanford University. And she can go ahead and wave if she wants. And J.D. Ouellette is EQIP's Director of Lived Experience, formerly the Director of Mentorship, and an educator who came to this work after the youngest of her 4 children developed anorexia nervosa in 2012. Grateful that her family benefited from early aggressive intervention with evidence-based care, she channeled her gratitude and personal and professional skill sets into ensuring all families have access to the same psychoeducation, skills coaching, and support that made the difference for her family and enabled her daughter to achieve full, robust, long-term recovery. And so with that, I'm going to turn the presentation over to you, Dr. Cara and JD.
Thanks so much. We can go ahead and get started. JD, do you want to put that into slideshow? Oh,
Sorry, Cara. I was saying I had it was showing slideshow view for me. It wasn't showing that for you.
No, it wasn't showing slideshow. It was showing the whole screen. It wasn't showing that for you. Interesting.
Okay, let's try that one more time.
There we go. Perfect.
There we go. Okay.
Success.
Yeah. I don't know what happened before because it looked right to me.
We're good. We're good. Yep. That's just us. Thanks for having us and listening this week. And we can go to the next slide and go over the learning objectives. So essentially, what we want to talk about is incorporating family into eating disorder treatment and recovery. And our learning objectives focus on first the why. So basically understanding why it's important to engage families and other supports in the treatment and recovery process. Who, so being able to identify which members of the family or support system should be involved in the treatment and recovery process. And then finally, be able to employ some effective strategies, identify what those common roadblocks for those strategies might be, and what support looks like in different situations, different applications. And we'll start with the why. So why is it important to include family into treatment? So I like to start this by an acknowledgement of the status quo of our eating disorder treatment. So treatment and recovery for the vast majority of patients with eating disorders has been largely an independent endeavor. Folks are getting treatment independently. They may go off to residential centers or more higher levels of care for treatment on an individual basis, and then go back into their families. But during that treatment focused time, be very individually focused. And the status quo of our eating disorders doesn't result in great outcomes. We have $65 billion in annual costs of eating disorders, according to some economic reports. And this is even if, that's understanding the fact that even getting into treatment is hard. So we see a lag of 5 to 7 years between symptom onset and treatment. This can be due to different misdiagnoses, but also just the fact that it can take a whole lot of motivation and agreement that there's even a problem to begin with to even get into treatment. Rates of treatment access are low. About 20% of people with an eating disorder even get care to begin with. And then when they are in treatment, we see pretty high dropout rates. So some evidence that an average of 24% of patients who are having CBT for an eating disorder drop out of treatment. The remission rates are not super great. We see still, 50% or more who don't show remission after our treatments. And then when we do, we still see high relapse rates. So, systematic review of relapse studies for anorexia nervosa, for example, showed upwards of 52% of patients discharging from higher levels of care showing relapse for their anorexia when they come home. And again, we think about that like if you're going somewhere independently and recovering in a setting, and then you come home to a family, to loved ones, other social support network who weren't there with you in the course of your care, in the course of your treatment, then how would they possibly know how to support you? And so if we think about this independence in the treatment journey for a lot of our patients, it's not that surprising that it would be so challenging to have this kind of separate world where you've almost got like your recovery world and your recovery journey where you are independently working with treatment providers and experts to recover, and then have folks who you're there with on a day-to-day basis who don't get it and don't understand and don't know how to provide that support. And so as we think about the challenges that patients face in accessing care, in achieving remission when they're in care, it makes sense that we're seeing this struggle. The other thing I would say in this regard too is we're asking patients to do something multiple times a day that is so incredibly hard because they're fighting their illness. The eating disorder itself often creates this motivation shift that waxes and wanes over time. Understanding that your illness is even a serious problem is characteristic of eating disorders that is a challenge to, being able to say, yes, in fact, I think this is problematic for me, is something that's challenging in the presence of an eating disorder. And even through the course of a day, you might say, yes, I want to recover. Yes, this is a problem for me. And then you sit down to eat lunch And gosh, that eating disorder is really loud and really hard and really challenging. And doing that independently on your own is so incredibly hard. It's actually why a lot of residential centers exist for eating disorders, because that support of staff to help you with all those meals and with stopping compensatory behaviors and things is so helpful. So the question around families to me is thinking about, okay, if we know how valuable support is, why not bring loved ones in? And so I'll pass this on to JD to talk a little bit more about what family brings.
Yeah, so thinking about how we can do things differently and make sure that everyone is involved and the whole environment changes, I think is what is beyond a lot of this, right? So we know that family-based treatment and variations of family-based treatment do have the highest remission rates of the treatments evaluated. And that leads us to sort of think about why that would be. One of the reasons for that is, as Cara mentioned, motivation. Motivation is always going to be something that is very hard. I often explain to parents, motivation is great until it runs into the brick wall of the eating disorder saying, I don't think so, right? So we have healthy loved ones. If they're educated, if they're given skills, they can be the ones who remain focused, who remain steadfast, who provide the motivation when the motivation in the individual wanes. We can also use the folks in the family and other caregivers in their environment and supports to set up a pro-recovery environment in day-to-day life. We think about what are some factors that precipitate the development of an eating disorder and what are some factors that maintain an eating disorder. I am sure I'm preaching to the choir when I say that diet culture is the sea that we all swim in and very much at odds with recovering from an eating disorder. So if we can bring everyone in and change the entire ecosystem, doesn't mean there was anything wrong with it to start with, but it means that there are ways that we can change it that support recovery and support family bonds. Reinforcing skills that patients are learning in their treatment by having loved ones learn them too is, I think, absolutely huge. One of the examples I often say is that if you tell someone to calm down, I don't know about you, but that has never calmed me down. That has done the opposite of calming me down. And yet we often say to people, we know they've learned things in a residential program or somewhere else, and we know they have skills, so we will say to them, use your skills. Pretty hard to think about which skills and how in the heat of the moment. So if the folks around you are also aware of what they are, they're better able to support you. And then making tough choices, again, relating back to that motivation piece of it. When the eating disorder is so strong, the patient can't fight it on their own. If everyone is involved, they don't have to fight it on their own. And that's really, really important. And then I think that information sharing, that is a two-way street between a clinical team and a family and other supports, makes sure that the clinical team also understands what's going on from the basis of maybe some more unbiased reporting versus just what the eating disorder wants the clinician to know. So who can do this? Parents, grandparents, and other caregivers are just a natural fit to support children, adolescents, right? Even young adults or emerging adults is the term that I'm really, really liking these days. And sometimes even with older adults, we can see people in direct roles around meal supervision, meal support, meal preparation, that sort of thing. And in other cases, in less of a direct role, but still a strong support role. Spouses and partners. This impacts everyone, right? So if you are a spouse or a partner of someone with an eating disorder, this really is your life too. And so we can work in the function of a team, working with the family together. Let's define this role. Let's define this role for your family unit, for you as a couple, whatever that is. And for some people, that support is going to be, I'm just going to be your cheerleader. And for other people, it's going to be, I need more support and here's how you can help me do it. Kara's going to talk more about siblings, but they really do occupy a space where they are really deeply impacted by the eating disorders and often feel very powerless. They often are really impacted by this. And so considering them in all of this process, both how they can be supportive and what their needs are, really important for the entire family system. And then one of the things that I find like incredibly just transformative to work with is thinking about who are the other people, right? Not everyone is going to have a traditional family setup. So we can help people with chosen family, with friends bringing into this, and even with colleagues. Very often your coworkers are the people that you eat lunch with, right? And everybody who's been in a workspace knows you can form close bonds. And if we can bring those people in and give them some education on how to do this, they can be really helpful. So we've got the moral and logistical support for some people where it is accessible to them.
Yeah, and I'm just going to double click on that last point actually too to say we also work with a number of college students and have had them bring roommates in to treatment. Just thinking about like the ways in which their roommates, it's not a romantic relationship. They're not a significant other. But they're just as impacted and can be so helpful and often really want to be helpful too. That's another thing. It's not even, I think a lot of patients are like, well, I don't want to burden my roommate with this. I don't want to be, I don't want to be another thing that they have to think about or worry about, but they're already worried. They are. So they come in and they're already thinking, like, I wish I could help. I don't know what to do. And this actually gives them something tangible to do, to be a part of it. And that's a great segue actually to talk about siblings too, which is that I've had so many. I'll just start. Siblings are often actually some of the first people to notice that an eating disorder is present. They start noticing that things are getting hidden, or they notice that meals are being skipped, or they may notice that binge eating is occurring by identifying that there's like wrappers being hidden somewhere, and so they often know that something is wrong, whether or not they're talking about it or not. The other thing that I think is important for siblings is there can be a risk, an elevated risk in siblings of developing their own eating disorder. And so being a part of the conversation and having that openness creates that trust in the family, that they can talk about what's going on for them as well, and can be preventative and supportive for them as well. Even though intuitively there are I've worked with a lot of parents who instinctually say, oh, I want to protect my other children from this. I'm worried that they might get ideas, or this might filter into them, or kind of they might catch this in some way or get ideas. And I think that it's counterintuitive in some regards, but that sometimes having that open conversation is actually protective, and gives them a space to have those ideas out in the open. The the other thing is, just like I mentioned with the roommates, because they're often the earliest ones to see what's going on and know what's going on, they also get worried, and they also get confused, and they also get they want to help, they want to be able to do something. Bringing them into treatment actually gives them a toolbox to use to say, okay, here's, I want to be able to do something. I feel helpless. So now I know. So the way we work with siblings in the context of FBT, for example, can be like, could you be a distraction for your sibling during meals when things are hard? Can you, play games with them to distract them after meals when they're, we're trying to keep them out of the bathroom? Can you, kind of help give them a job, so to speak, that's not another parent, that's not the food police, but is something that they can do to be engaged and feel like they're contributing in a positive way. I have experienced when siblings aren't included that they get confused and they get worried. They have a hard time understanding why are dinners so stressful? Why is everyone fighting or yelling, or why is food getting thrown? And that lack of understanding and uncertainty can be really scary.
And Cara, we have some sort of patient stories to highlight, and I just want to share one of our families where a little brother, in the midst of a breakdown, went and got a family photo album and just started sitting at the table, just talking out loud about this amazing family vacation. And that turned out to be the thing that was always going to bring his sister back and help her push forward.
Yeah, I love that. I also had some siblings once where everyone was struggling to figure out, what is the distracting thing that I can do during dinner. And it was a brother who said, everybody loves talking about the dog. Like, let's just talk about what funny things the dog did today, and things like that. So they can come up with some great ideas. I noticed in the chat someone asked about younger siblings, and I actually have a great story on that. I had years ago, had a family who came in who brought their 4-year-old kid in their mind just because they didn't have childcare for for their 4-year-old, and really didn't think, oh, I'm bringing my 4-year-old to be a participant in family-based treatment, but really I just don't have childcare, so he's got to come along. And so they set him up with like a coloring book and crayons, and he was sitting on the floor of my office, sitting there coloring. Everyone thought that we were all talking and that he was just, in his own world coloring. He was not in his own world coloring. He was absolutely listening to everything. And as the family was talking about some of their concerns around eating, he just pipes up and he goes, "Well, I saw her do X, Y, and Z," and he just started contributing to the conversation around things that he had observed and he had noticed. And so, although everyone thought, here he is, 4 years old, he's probably not aware, he's probably not paying attention, he absolutely was. And it was helpful for him to be able to vocalize and be a part of what was going on for the family too. So I think you'd be surprised at some of the younger siblings' observations.
So let's talk about the how. So what are some of the treatment models with this embedded family support? Most people are most familiar with family-based treatment. Historically, that's been for children and adolescents under the age of 17, and based really on very direct caregiver management. There's just a meta-analysis that came out a few days ago that talked about the various ways FBT can work that are maybe not always traditionally full family, and that can be helpful. We are huge fans of temperament-based treatment with supports. That is a much newer model. It's often an adjunct to other treatment models, and it really focuses on everyone, the patient, the family, everyone understanding what's behind the eating disorder. And I don't necessarily mean that just sort of in like an underlying trauma cause, but when Cara was doing the introduction about the work that she's done, when we talk about what's behind it, that can include a lot of things that are really helpful to understand: biology, brain function, genetics, personality traits, and then all of those traits are always going to have something positive attached to it and something negative. And the eating disorder is often using those in very negative ways. And through psychoeducation and skills training for everyone, we can harness those then to use them in really positive ways. Family-based treatment for transition-age youth, again, that's for young adults, primarily dependent on their family, often college-age years. Really liking the term again, emerging adults, because I think it really is a lot more clarity about what that population is. And then emotionally focused family therapy, which again can be adjunct to other treatments and really empower supports to develop just this wide range of skills. And through the use of not just education, but scripts and things like that, really help people begin to provide support in a compassionate, validating, effective way that really strengthens family ties versus being negative.
Yeah, and those are the treatments, the evidence-based treatments that have been studied that include families, and loved ones by the nature, by the design of the treatments. These are two treatments: CBT, enhanced cognitive behavioral therapy, or CBTE, and cognitive behavioral therapy for ARFID, or CBT-AR, that are often delivered as individual independent therapies, and yet they do have adaptations out there, or there are versions of them that incorporate loved ones into the care, and we find them to be incredibly valuable even across the lifespan, across the lifespan for patients of all ages, of ways in which loved ones can be included in the course of, if we think about CBTE, for example, there's a lot of work around behavior change, of monitoring around meals, noticing patterns of when triggers happen, and things like that. And loved ones can help reinforce some of those things. So if you notice patterns that, gosh, lunch tends to be really hard for me. So then could you include your mom or your significant other or somebody in lunches? Can you do, certain things and be able to incorporate them into your treatment planning? CBT for ARFID, one tool that's used in that treatment is exposures to new foods, exposures to different foods that you want to expand food variety, for example. Loved ones can be really helpful in supporting folks in getting those exposures accomplished, and things like that, and just overall general support throughout the course of treatment.
So we take a little look at what this looks like at different life stages.
So when we think about children, adolescents, this is a prime age group to do FBT with. And so if we're using an FBT treatment model, then of course parents are embedded into that as well. They can be the folks who are there for every meal, plating meals when needed, working on transitioning to independence when the child or adolescent is ready for more independence around food. But the other thing that I like about including families into treatment is thinking about the ways in which they may, JD says this all the time, and I wholeheartedly believe, that families don't cause eating disorders, and yet sometimes there are things that happens in the context of families that can make it hard to recover, and things that may need to change in order to create that pro recovery space. And so, like there was a patient that we treated who had binge eating disorder, a teenager, I think around 14 or 15. And it was really challenging. Her binge eating disorder was really driven a lot by some of the restriction that was going on, the food restriction. She had these patterns of restriction and then loss of control after that, and these common binge restrict cycles. What was challenging for her in identifying this and addressing this pattern for her was that she had been told by a doctor previously that she needed to lose weight and needed to go on a diet, and that her parents were they had heard this message, and I want to really stress that this was not these were parents who absolutely loved their child and was doing what they were told from the doctor to do, and really believed. But this kind of diet plan that the family was enacting in order to create a way, to lead to weight loss, was really reinforcing this binge restrict cycle for her. And so bringing her family into the treatment meant that her family was able to learn about that binge restrict cycle, learn about the ways that, she really needed to be eating foods throughout the day, that she needed to be not overly restrictive in certain food, types and things like that. And that education of the family was so vital in being able to create an environment for her, which she didn't buy her own groceries. She was 14 years old. So, she needed her family to really understand what she needed for recovery.
Young adults, transition age youth, emerging adults, it really is rare in the USA for this population to be very logistically, financially, and always separate from their families. And I really like the question about, can you use this if people are away, totally independent, away from home, at home? And we actually have a lot of good luck, even when kids are in college, of doing this whole family, bringing this family into it. So there's lots of approaches to take. There's ways to balance it right toward that developmentally appropriate independence, and also the elimination of eating disorders so they can begin to live their adult lives without the eating disorder. I will often say, and I'm a parent of someone who did this through my daughter's emerging adult years, autonomy for me was not more important than autonomy from her eating disorder. She had to have that autonomy from the eating disorder in order to then go on and have autonomy from her family in the appropriate way. She's, by the way, is trained to be an FBT therapist now. And I think of a story, an ARFID case we had with a 19-year-old who did pretty well with pretty straightforward FBT for ARFID for many years at home. And her family wasn't aware how much of that was dependent on the way they prepared food for her. So they sort of knew what it was that she needed. They were able to accommodate that. It wasn't a burden for their family. And they were really unprepared for what happened when she went to off to college, which was that lost a lot of weight, really sort of tanked, that sort of thing. And they were able to come up with a plan that sort of balanced everything. When she came home, they sort of kept an eye on things for a few weeks. And then when she came home for winter break, were very, very aggressive in refeeding and weight restoration, and really had her at a higher weight than she'd gone before. And that put her brain space into a place where then she was more effectively able to work a little bit more independently with her team on how to sustain what she needed at college, given those resources, with a very hard backstop of, if the weight drops again and the behaviors spike again, we're just going to need to come home from school and take a longer break. And it's worked really beautifully for this family.
and adults. So we know the ways in which recovery is so challenging, and doing it independently is hard. And so unlike our children, adolescents, and our emerging adults, where there is a family often right there surrounding them anyway, our adults come with wide variety of families and loved ones available to support them. And we find that whoever those people are, that can be so incredibly valuable to their treatment. There was an adult recently that we treated who had anorexia nervosa, had really longstanding, duration of her illness, and had been in and out of hospitalizations over the course of her young adult life. And at the most recent hospitalization was discharged, and her significant other was like, look, I don't know where our future is if you keep getting sick. I don't know where, and didn't want to put her in a place of kind of an ultimatum of either you recover or we're kind of done, but it was really in a thoughtful way, being like, I want to have kids with you. I want to have but what is our future if you're not able to recover? What do we need, and what do we need to do? And he was able to really talk to her in a way that was not in a like, you must fix this, and instead was like, how can I help you fix this? How can I help you? And so he was able to then join her in treatment for the first time, that she had someone, able to really be there, and they could work together and say, okay, this is what I need. And he was able to support her through meals, and sit with her. She also, and this is, I think, something interesting, that a lot of our adult patients will actually get support from their parents as well. So she had her significant other, but also had her parents supporting and involved and able to jump in. And so she had meal support with her significant other. She had meal support sometimes with her parents, and the ways in which you can kind of create your village, even as an adult, to help support recovery.
And it was very important in this case, too, for him to have the knowledge and support from her parents who'd witnessed this for a long time, to be able to give him information, and then from them to be able to exchange information, and him to have enough of his own really knowledgeable support that he was able to not burn out and move forward. So what are the nuts and bolts of this? First, the most important thing is always going to be non-judgment and non-blame, and meeting people where they are, right? If this was easy, everybody would be well. If the information was easy to be found, everybody would have it. And we just know that's not true. So starting from that place is really important. And even if diet culture has been heavily prevalent in the family, we don't change people by blaming them, right? We change people by understanding them and educating them. So again, that psychoeducation around the eating disorder, around precipitating and maintaining factors, and then skills building, right? For folks working with eating disorders, it can be challenging. It can be frustrating, right? Certainly very true in your own home. And understanding specific techniques, understanding why the motivation isn't consistent throughout, really, really important. We talked about changing the way the person's life is and the family's life is, very important. Understanding what a recovery supporting environment looks like, how to build this at home. It's not intuitive. It is not the way most of us are set up. I'm a huge fan of patients to support learning their skills separately and then learning them together. There is nothing like the person who is less emotionally dysregulated being able to say, let's take a breath, and hey, I have a thought about a skill that might help us get through that moment. Can we talk about that now? Can we work on that now? And over time, the person then is able to access that independently, but it's a scaffolded process. Lots of logistical and practical support, right? Scheduling appointments, grocery shopping, attending things, interrupting the behaviors, right? It's overwhelming to recover from an eating disorder. Why wouldn't more support help? Taking decision off the patient's metaphorical plate, right? We know that choice, decision paralysis, these things are very real with folks who are prone to develop eating disorders, and particularly in the midst of their eating disorder. So sometimes it can be a real gift to remove a lot of choice. One of the ways I talk to families of particularly of young adults who are very concerned about this is we're talking about protection, not punishment, right? We all have the same goals for recovery, independence, all of those sorts of things. And sometimes we need to protect them from the eating disorder to be able to support that. And then again, this two-way street. We talk about this so much at, in the work that we do. It's just this continuous feedback loop where families can give information, families can get information, all of that, and all of that facilitates the clinical experts on the team being able to understand where things are and provide the best support that they can.
All right, and our last section is on the challenges and what it can actually bring as we get through it. So, JD and I came together and thought of some of the key challenges that we see in this work. But one thing that comes up, and this is very common in family treatment, but in other situations where we're bringing the family in, is parental alignment. So if one parent in the family is thinking, oh gosh, this isn't really that big of a deal, it's not that hard, why are we doing all this effort, why are we making all this effort, and another one is like, oh my gosh, are you kidding me, we need to be at every meal, we need to plate at everything, and if there's a misalignment, then that can create challenge with being able to just be successful. We often will, work with families and say, okay, hold on, let's pull back. Where do we have agreement? Where does everybody agree that there's a problem? And then how can we come together to identify what the next step is going to be? And what we find is that working through that challenge of parental alignment actually often leads to stronger family connections and the greater ability to work through those challenges in the future. But I often hear, families say, gosh, I wouldn't wish this eating disorder on anyone, but wow, our family is able to work together in a way we never were able to work together before. Diet culture and the challenge and the threads of like, gosh, well, I've been taught my whole life that we need to kind of not eat desserts too much or not have carbs or not have sugars. And, this is the messages that I've been getting so much. And yet, how are we, that's not working in the context of eating disorder recovery. Where we see this growth happen is in creating advocacy together and families being able to work together to say, oh gosh, look at the ways the diet culture actually hurt us and harmed us in creating a world where they can, start to make change in their own communities. Fear of distress and the impact on a relationship is something I see from families a lot that, it's like, gosh, well, I want to rock the boat. I don't want to kind of push on, eating pasta. Like, it's okay. Maybe they could just stick with salads, because the pasta is just too distressing. It creates fights. It's too hard. Or aligned with that, I'm worried that if I push too hard, that my child's not going to, want to be around me anymore. Or, if it's another loved one, like it's going to hinder our relationship. It's going to somehow impair our relationship. And what we have found is actually this greater ability, this moving toward distress actually gives the opportunity for the loved one to learn and grow in those emotion regulation strategies that actually identifying that distress creates opportunity to say, hey, how can I tolerate this and how can I manage that? It's going to prevent bad things from in the future. And then really being able to support each other ongoing. We see so many times people will say, I was so angry with my parents for making me do this and getting through this, but now I'm so grateful. And I can't, imagine how life would be without this. And then finally, just lack of confidence, not knowing the tools, not having the tools, and just the ways in which the skill building in the context of eating disorder recovery, that they can then apply to things even beyond and ongoing.
And to that point Cara made earlier about sort of things I say about parents causing eating disorders, I always say, while you didn't cause it, I've never met a family that didn't have to change to fight it. And I think that's true. I never have, and it's been a minute now. And then also want to share what Kevin Dunn, our family mentorship director, says in that service of non-judgment and non-shame, is he's like, look, your family's operating software didn't need these tools before, and now it does. We're just here to help you upgrade your iOS. And that really resonates with people, again, that it's not about what came before, it's about what comes from now on.
I want to stop right here. This has been such a great presentation. Thank you so much, Dr. Cara and JD, for presenting here. We've run a little bit over our Q&A time, so I'm going to hand this right over to Dr. Yolanda Evans to help introduce our case presentation. Thank you.